Good afternoon, everyone. Thank you for joining us today for the webinar with Dr. Ramana Naidu, speaking about low back pain and sacroiliac joint pain. Before we get started, I have a few housekeeping comments for you. There is a question and answer box at the bottom of the page. Feel free to type in any questions you may have during the webinar, and at the conclusion, Dr. Naidu will be answering those questions. The webinar will also be recorded, and I will be reaching out to you directly at the conclusion. Again, my name is Patrick McMorrow, work for Pain Tech along with Dr. Naidu, work with him. And yeah, if you have any other questions, like I said, I'll reach out to you all directly. And now without further ado, I wanted to introduce you to Dr. Naidu. He is the medical director of pain management at Marin Health Medical Center and the medical director of Marin Specialty Surgery Center. So Dr. Naidu, here you go.
Thank you so much, Patrick. And thank you to the Pain Tech team for giving me the opportunity to talk about this therapy. And especially all of you on this call today. We really know your time is precious, and we appreciate you taking the time to learn about this therapy. The sacroiliac joint, just before we get into the content of the slides, has always been sort of the great enigma in low back pain. A lot of people, physicians, surgeons, kind of dismiss it as a pain generator. They think, well, why would this joint, which hardly moves in the human body, create such discomfort and suffering for individuals? Because historically, we've thought that joints that do a lot of movement, like the shoulder, like the knee, like the hip, and even the discs, which are actually joints in the spine, have been the sources of pain. But we've really changed the way we've thought about the sacroiliac joints as a source of pain over the last several years. And we finally have a therapy that actually addresses two of the issues, with number one, the joint getting compressed over time, and then number two, the motion, which can increase the pain from that region. So we'll get into some of the details about this particular procedure from Pain Tech, but before we do so, we'll go through an overview of the sacroiliac joint itself. Next slide. So the first question is, have you ever felt this way? And these are comments and statements from patients who have come in with sacroiliac joint related pain. So when I try to stand up after sitting, the pain is unbearable. Or somebody else would say, a car ride to the store has me shifting in and out of my seat just to stay comfortable. So they're sort of leaning one way to take pressure off of one side and then leaning the other way to take pressure off of that side. The next patient, the injections I tried have helped for a few days, but then they came back. And as many of you on this call know, that can happen. There's a good and bad with that. The good is if you do get relief, even if it's just for a day or two or three, it means that's the pain generator. Obviously, you're looking for weeks, months, if not years of relief. And that's the therapeutic aspect to it. So if an injection just gives you a couple of days of relief, the good news is we were in the right location. It's just that the steroid didn't kick in, or whatever else we injected didn't kick in to give you the long-term relief. So even with that experience, there is a glimmer of hope there that we can go on to the next step to really address the issue. The fourth patient, if I move the wrong way, I scream. So that is absolutely true with the sacroiliac joint. It can shift, and certain movements like sitting on a hard bench or leaning over in a particular way on a stool can really cause severe pain. And then the last patient, the pain, I couldn't get rid of it. I was in so much pain, I couldn't do anything. I couldn't unload the dishwasher. The pain was taking my life away from me. And this was just somebody I saw 2 weeks ago who literally couldn't do the dishes, and that was affecting their life, and the pain was quite severe. So these are all the types of comments, statements that might resonate with you if you're somebody who's listening in and feels like they have sacroiliac joint related pain. Next slide. And we've tried so many different things. So as we all know, we typically start with conservative measures, which is great. So physical therapy, over-the-counter medications like ibuprofen, Aleve, acetaminophen, or Tylenol. We see other providers such as chiropractors. We may go on to see interventional pain physicians such as anesthesiologists or physiatrists and have injections. We may have radiofrequency ablation, a procedure where we gently, quote unquote, burn the nerve in a manner in which it stops signaling pain. And so a lot of different things have been tried for this particular issue. And what we have seen is that for some people, the pain comes right back relatively quickly, and they want to know what the next step is. And as you can see from this bullet point list, I mean, some patients go on to have a spinal fusion because it looks like there's something wrong with the lumbar spine when in fact, the issue is coming down from below the sacroiliac joint. So I've had a number of patients come back after a fusion surgery say, the pain I went in with didn't get fixed by the surgery, you know, now what do I do? Or even my pain got worse after the spine surgery, now what do I do? And that can be because the sacroiliac joint has masqueraded the low back pain, where people think it's coming from the lumbar spine because the MRI looks a little funny, the lumbar spine, but when in fact, the whole time it was the sacroiliac joint. And we have people who get injections into the sacroiliac joint who unfortunately don't see any sustained or significant relief. And even if that happens, that doesn't mean we're in the wrong area. It just means we need to find a better therapy. And that's where the pain tech link system can come in and be super helpful. The last bullet point, spinal cord stimulation. This is something I do quite a bit of. And it's been a really effective therapy for most things, but not the sacroiliac joint, frankly. So I have a lot of patients who have spinal cord stimulators who do really well with some of their low back pain and their leg pain, i.e. radicular pain. But they come back saying, hey, my low back still seems to be an issue. And after some diagnostic injections, we find out it is actually the sacroiliac joint. Next slide. So sacroiliac joint dysfunction, this is just an overview of the anatomy for those of you who don't know. So what you see here on the right is a skeleton or a model of the pelvis. So the sacroiliac joint, even though we're talking about low back pain, actually doesn't have to do with your lumbar spine. It's actually all the way down at the sacral spine, which then goes on to become the coccyx or tailbone. Now, in between the sacrum and the wing bones, if you will, or the ilium, is the joint called the sacroiliac joint. You can see that circle here on the left-hand side denoting the SI joint. So sacroiliac comes from the two bones, the sacrum and the ilium. And then the distance or the space in between is the joint, the sacroiliac joint. Now, there are a lot of reasons people can have irritation in this joint. First and foremost, this joint gets the most use or range of motion during pregnancy. So when women are going through pregnancy, that joint really opens up. It changes the shape of the pelvis. And then after delivery of the baby, the pelvis closes down. And that's really where we see it move the most. Now, the good news is women are having babies, you know, in their 20s, 30s, 40s. And generally, the degeneration arthritis isn't significant enough to cause major discomfort. Now, with that said, I do see women occasionally, soon after pregnancy and delivery, have significant sacroiliac joint dysfunction related pain. But as we all get older, whether female or male, those joints, which have a relatively low level of motion, do develop arthritis, just like you see in all of the other major joints, like your shoulder, your knees, and your hips. And what arthritis is inflammation of that joint. And we can see that via X-ray or sometimes even with an MRI or CT scan, and it'll show bone spurs, it'll show sclerosis or where the bone starts to remodel in a certain way. And that can suggest that that joint is the source of pain. The latest evidence shows that the SI joint can be seen in 1 in 3 patients with chronic low back pain. So this is a very, very common issue. And for those of you on this call who've seen me here in clinic, my job is always trying to figure out what is the source of your pain. And sometimes it's more than one thing. Sometimes we figure out, oh, it's the facet joint, or it's the nerve root, or it's stenosis. And it also turns out sacroiliac joints are also playing a role. And many of the other interventions often perceived to fail due to mechanical pain have been overlooked. So we go on and we leave this as an untreated disease. So for example, we have people who have sacroiliac joint injections. You know, the first one works for 3 months, great. The next one works for 6 weeks, okay. The next one works for 2 weeks. And some of those patients say, forget it. You know, I'll go on and see somebody else. And historically, before this pain tech procedure, you know, we tried radiofrequency ablation, which worked some of the time. It works about 60% of the time, giving patients at least a 50% reduction in their pain. But now we have a therapy that can last much, much longer period of time, if not indefinitely, because it stabilizes that joint. Next slide. So again, this is another model of the sacroiliac joint. And you can see here now where it relates to the lumbar spine. So what I tell people is if you sort of feel that low back pain right at where you would wear your belt, if you wear a belt, or basically at the lowest part of your low back, at the lumbosacral band pattern, that is where the sacroiliac joints are. And some people, you can feel a little dimple there. So if you have a little 2 dimples on the side of the low back, that's usually where the sacroiliac joints are. If you can push on those areas and feel some discomfort, that is suggestive of sacroiliac joint dysfunction. Now, the SI joints are covered with a network of ligaments. Now, ligaments are basically connective tissue between 2 bones. And this model here you see on the right doesn't really depict those ligaments, but I'll tell you, there's a huge web of ligaments surrounding that joint, both in the front and the back of that joint, and that connect to your lumbar spine and all the way down to your lower sacrum and coccyx. Now, when those ligaments become really tight or too loose, that can result in the dysfunction of the sacroiliac joints. And there are a lot of reasons for that. It can be normal wear and tear as we all get older. It can be people with connective tissue diseases or Ehlers-Danlos syndrome. These are situations where the connective tissue actually has a problem, and it leads to increased mobility of the SI joint, which can lead to more grinding or erosion and arthritis of the joint, which can result in continued low back pain. So it's important to think about those ligaments. That's one of the things that physical therapists will work with you on when they see you for sacroiliac joint dysfunction. They try to work on ensuring the ligaments are doing their job to the greatest degree that they can. Now, sacroiliac joint dysfunction can occur as a result of a fall, a work injury, a car accident, and as I already alluded to, pregnancy and childbirth, or a hip or spine surgery. So if somebody has a fusion of L4 through S1, or they have a total hip replacement, the joint in between the lower lumbar spine and the hip is the sacroiliac joint. So if you put a fusion in or replace the hip, the shock absorption is reduced in that joint. So what happens is those forces transmit to the adjacent joints, i.e. in this case, the sacroiliac joint. And so people can see continued pain and dysfunction in that area. I just saw somebody this morning who had bilateral hip replacements, and sure enough, they presented with the hallmarks of sacroiliac joint dysfunction. And my explanation for that individual was that the forces have now transmitted up to your sacroiliac joints. Now you're coming in with low back pain. Everyone was assuming it was your lumbar spine, it was a disc, when in fact, it was the sacroiliac joints. So strong ligaments and muscles can support the SI joint. So I do want to reiterate, we do depend on physical therapy. Just because it doesn't work sometimes doesn't mean it's not important. So we do have our physical therapy group here at California Orthopedics and Spine. When I send patients for sacroiliac joint dysfunction, they will work with you to strengthen the ligaments and muscles around that joint. Even though there's a very small range of motion, we can see some arthritis and ligaments stiffen over time. And then what happens is the cartilage inside the joint will break down and result in the bones rubbing against each other. When that happens, that sets off the nerves within the joint and outside the joint that send the signals up your spinal cord into your brain to say, hey, brain, you have some low back pain, either on one side or both sides. And then you see the doctor because it becomes so severe, and now it's the doctor's job to figure out where is this pain coming from. And it's not easy. Some of you have probably seen a number of different providers and still don't have answers. And now, hopefully, after today's webinar, you'll think, well, maybe it's my SI joint. So hopefully, if you're hearing something that resonates with you as far as your pain, you may want to see myself or somebody else in your community who can help you with this particular issue. Now, the symptoms can include low back pain, buttock pain. Sometimes there's pain that goes down the leg, but it usually stops at the knee. So one of the questions I ask patients is, does your pain go below the knee? And if so, that suggests it's a radicular type of issue coming from the lumbar spine. However, if the pain stops at the knee and stays above it, that might suggest the sacroiliac joints are at play. And this pain can worsen with a lot of different types of positions. It can worsen primarily with sitting or with going from sitting to standing. So if you can get off a chair without using the arms of the chair, so you keep your hands up here and you try to get out of a chair, and if that's painful, That suggests SI joint dysfunction. It can affect you when you're standing. It can affect you when you're going upstairs or walking, and it can affect you even when you're in bed. If you're a side sleeper, you're going to put pressure on one sacroiliac joint, and you might notice yourself tossing and turning, trying to get into a comfortable position because those SI joints are being inflamed with every particular motion. Another thing you can do, I'll just add on, is if you can just brace yourself on a drawer or a dresser and then stand on one leg and then try to squat down on that one leg. And if you feel the low back pain there as you do that, that again suggests the sacroiliac joints are at play. Now, be careful when you do that. I don't want any of you falling. That's my number one rule, no falls. But if you can do that maneuver just to see if that sacroiliac joint is really taking on the pressure and causing discomfort, that is, again, very suggestive that the sacroiliac joint is playing a role in your pain. Next slide. All right, so now let's talk about the link procedure. So this is, the procedure is this, as an overview. What we are doing is inserting a bone allograft into the joint to do two things. Number one, it widens the joint. So it creates distraction or space in the joint because we're inserting something into it. And the second thing it does is it coaxes growth, your own bone, to grow across the joint. So some of you on this call who have had a fusion of your spine know that it resulted in screws and rods and hardware being put in metal. And that used to be done for the sacroiliac joint. Not any longer. Now we have these allografts, which use your own bone to grow across, so you do not have any metal or hardware. The other thing I mentioned, distraction, is really important. So if I just put this in the joint, and just put in some bone growth stuff, you might notice a little bit of relief because it stops the motion. But because that joint space has become narrowed and inflamed, you may not get the full benefit or the full potential therapy out of it. So it is really important that we open up the joint a little bit and then put in that spacer. So the series of instruments that we use, I'll show you in the next slide, are there to help open up the space and allow this allograft to be put in. This is FDA approved. It's been around for years. It requires a small incision that's about 1.5 to 2 centimeters, so less than an inch. It's an outpatient procedure. So you come into our surgery center, and sometimes we do this at the hospital in case there are any anesthesia concerns, but usually this is done at the surgery center on an outpatient basis. You'll probably spend a total of 3 hours. The procedure takes me about 20 to 30 minutes just from when I come in, come out, but there's anesthesia, there's the setup and everything like that. So give yourself about 3 to 4 hours at the surgery center. There's a very, very low risk of infection or any other complications because we are working in the joint. There are no major vessels. There's no major nerve around that area. So it is a very safe procedure. And it's a quick recovery time. I mean, usually people are feeling pretty good. I don't even prescribe routinely any pain medications afterwards. However, if you feel like, hey, I've had surgeries in the past and I've had some major discomfort, I'm happy to do that for you. It's just that on average, most people do just fine with over-the-counter medications. The only activity restriction I'll mention is we don't want you sitting for a really long period of time because that opens up the joint. So there are some activity restrictions for the first 6 weeks as far as sitting. But you can do as much walking, standing, and lying down as you want after this procedure. So really the activity restrictions are fairly minimal in the grand scheme of things. And most patients will tell me, well, I don't like sitting down anyway, it's painful. So that's not a huge request. Next slide. So this is how the procedure is done in these 4 steps here. So what we do is we start with a wire that's almost like doing the injection. An injection I do, 20 times a day here in our office. So this is that needle or wire here in the upper left-hand corner. The next stage is called a dilating stage. And that's where we put the series of instruments over the wire. And we're using X-ray to do all of this. So what it does is it opens up that joint space. So it's a tapered edge that as we get it into the joint to a greater degree, it opens everything up. And that's what it provides the distraction I was alluding to. And then what we do on the bottom right-hand side is place the allograft or the bone that's harvested from a cadaver, and it's completely cleared of any live cells, so it is safe. And then once we put that in, we take everything out. And so all that's left is that cadaveric allograft just sitting in the joint. So it's spaced, and now it'll coax your bone to grow in. And the reason for that bone growth that you create is because we basically rough up the edges of your bone. That sounds a bit harsh, that sounds painful, but trust me, it's not, because what happens is it promotes the bone, the cells within the bone to grow and to grow across that allograft. So that's the beauty of the procedure. It's basically making your body do all of the work. Next slide. So Patrick's going to show you an animated video. This will give you sort of a real-time overview of how the procedure is done. And this is a video you can look up yourself as well on the PainTech website.
PainTech's Link is an innovative way to solve patients' SI joint pain, using SI stabilization with a minimally invasive medical procedure. Patients get long-term benefits and faster recovery than other SI fusion methods. The process is broken down into 4 steps. First, the Steinmann pin is inserted into the SI joint, between the sacrum and the ilium. There is no drilling involved. Next, the tissue dilator and working cannula are inserted, creating separation in the joint. Then, the broach rasp is inserted to create room for the link allograft to fit comfortably and at the same time initiate decortication. The broach and rasp are removed with a simple unscrew, reverse hammer, and pull motion. Finally, a large graft window of the link allograft is filled with DBM and placed into the SI joint. The inserter ensures that the link is positioned perfectly, allowing SI fusion to begin. This step helps create the perfect growth environment for link to work. Link enables you to fix the pain, not mask it, allowing your patients the ability to take back their life again.
Thanks, Patrick. And as I mentioned, you have the opportunity to look up that video yourself, and I encourage you to do so. That might have seemed really fast, but that is, I don't go that fast, but pretty close in real time. So that was a great overview of showing you how the procedure is done. And as you can, I think, appreciate, it's relatively simple. This isn't something that was invented just a year ago. This is actually a culmination of years and years of trying to understand how to do a sacroiliac joint procedure correctly. In the 1970s, we were using screws. And then 10 years ago, we were using triangular rods. And now we've come to this really simple, almost like 4-instrument procedure. So I don't want to overlook the simplicity. That simplicity is based on years of complexity, but we've refined it to where we've come to the point right now where we can do this relatively quickly, but more importantly, really safely. Next slide. So what to expect after the procedure? I think this is, something many of you are very interested in. So first things first, after the incision, you can expect to have some soreness from the procedure. I'm not going to sugarcoat it. There is going to be soreness where the cut was and where we worked around the joint. But as I mentioned, most of that's relatively well manageable with over-the-counter medications and ice. So for the first 72 hours, we actually put a dressing on where you don't need to, do anything with it. We'll see you 2 weeks afterwards or 10 days afterwards to take off the dressing ourselves. You can take showers the next day. We just don't want you submerging in water for the first week. The reason for that is that incision is closed with Dermabond, which is a glue that keeps it relatively watertight, but it's not 100%. So we don't want you tempting fate and imposing any risk of infection. As I mentioned, the biggest activity restriction the first 6 weeks is not sitting for a long period of time. So I do tell people, try not to sit for longer than an hour at a time. If you need to walk or stand or lie down, no problem. You can do that all you want. I just don't want you sitting on a hard bench, for example, for hours. One of the first patients I did, he was feeling so great. This was before COVID. He went to a mall and sat on the bench for 4 hours. And he called me up afterwards. So, doc, my pain has come back. Like, what do I do? I said, what happened? You were doing so well. How did this happen? He said, well, I was feeling so good. I went to the mall and I sat on the bench for 4 hours. Because I love to do that. I love to go people watch and just, hang out and go for walks. And so I told him, we talked about this. We weren't supposed to sit down for longer than an hour. He said, I know, I was feeling so good. So that was a great reminder, not only to him, but to me, to really, use his example for others, because he was somebody who was doing really well 3 weeks, 4 weeks out of the procedure, and thought, well, I can probably sit down. And he saw, things go backwards. Now, after returning to the restrictions, he ended up doing really well, and he still continues to do well today. But it's a reminder for everybody else, just, make sure you're not sitting for too long of a period of time. Now, we do impose weight restrictions on lifting to 15 pounds or any major bending. As you progress through the 6 weeks, you'll probably find yourself able to lift a little bit more. But again, to be really strict, we like you to maintain a restriction of no more than 15 pounds. Next slide. All right, and so here are some patient success stories. I learned my back pain was SI related over a decade ago. Finally, thanks to Pain Tech, I found a way for this therapy to help. We have another patient out of Kansas City. She shows the less invasive Pain Tech procedure compared to doing a lateral approach or screws and hardwares, which do exist, which you can find surgeons doing. But as you just saw, this is a simpler, less invasive procedure. And the third patient, I was able to stop using pain medications after the procedure. I truly have my life back. And that is something we do see, is not only do patients start to feel better, they can do more activities, but they cut back on the pain medications they were taking. And it's not just opioid medications that we're worried about. That's sort of the tip of the iceberg when it comes to pain medications. We actually have concerns about even ibuprofen and Aleve, because those medications can increase to a slight degree your risk of heart attack and stroke. So really, any pain medication has its degree of risk. The question always is the benefit worth the risk? And if you start to find yourself taking these NSAIDs or ibuprofen-like medications for weeks, if not months at a time, you start to worry about risks those drugs can impose, like peptic ulcer disease or ulcers in the stomach, like kidney dysfunction. As I mentioned, an increased risk of stroke and heart attack. So it is important not just for opioids, but it's important for all medications to be off in patients if we can do something about it. And I think this procedure has the opportunity to do that. Next slide. So here's some videos of the testimonials we'll go into. Patrick.
That look.
Couldn't walk very far. I was in so much pain that I was willing to try anything. I've had injections, and I've also had bricks inserted into the SI joints, and they were not working. When it came to the point of being confined to home and losing independence, my reservations went on vacation. If you're going to prescribe medicine, I'm not going to take it. He says, that's good, I don't prescribe it. So we're going to get along just fine. To me, it was like pain-free. And trust me, I've had more than my share of procedures. He got me all prepped, took me back there, and then they said, you can get up now. I'm like, you're done? I mean, that's how quick and easy it was. I saw results right away. I just noticed that the pain is gone. It's great that I'm where I'm at. I'm back up and mobile, and I'm very thankful for every day that I live.
That's a very common story. We hear quite a bit. It looks like Patrick has another testimonial as well.
SI joint pain in the beginning, when I first came to Dr. Azim, was extremely severe, and it was the point where I was basically immobile. It was an effort just to get out of the chair, to walk to the bedroom, to go to the restroom. You know, my hobby and passion is fishing, and to lose that was very frightening. You know, at first, of course, you have some reservations, but the way Dr. Azim explained it to me and how the procedure would work and how simple it was really a no-brainer. It is a relatively non-invasive surgery. It's just a small incision, and then when you come out, everybody's so pleasant and nice. Well, if I had known sooner about the procedure, we'd have done it 2 years earlier. We went just as soon as we could get approval, and he'd done the diagnostic injections prior to it. It's an amazingly simple solution. There's no after feeling or that there's anything there. I just feel normal. And my pain was reduced by 85 or 90%. Fortunately, after having the surgery, I've been able to go out in the boat, and we've been out several times.
All right, so that's another great testimonial from Dr. Azim out in Florida. We'll go to the next slide. All right, so some frequently asked questions, and I think I'm seeing some of those questions already coming into our Q&A box. So this is an opportunity for all of you who are listening and watching to put in your own questions as well. I think some of these questions we'll answer right here. So the first one is, does it require an overnight hospital stay? And no, this is an outpatient same-day procedure. As I mentioned, usually it takes about 3 to 4 hours total by the time you drive in and by the time you drive out, as long as your ride is there waiting for you. It's a relatively quick procedure from my standpoint. And as you just saw from the testimonials, it doesn't take long for you to wake up and kind of get out of the surgery center. And this is typically done in the surgery center. Although, as I mentioned, there are some patients who have this in the hospital because the anesthesiologist just want to watch their heart or their lungs a little bit more closely in the hospital setting. I believe this is one of the questions that came in our Q&A. Is this covered by Medicare? And the answer is yes, this is covered by Medicare. And there are several private insurance companies that also cover this. For the private insurers, we do have to go through an authorization process, so that it can be a little bit protracted. But nonetheless, for Medicare, the authorization is basically inherent. There is a code for it, and you're ready to go. If you've had a prior fusion or laminectomy, am I still a candidate? And the answer is absolutely. In fact, individuals who have had a laminectomy and or a fusion will often develop sacroiliac joint related pain or dysfunction. And the reason for that is, as I already alluded to earlier in this talk, is that when we fuse the lower segments of the spine, it results in transmittance of forces to the adjacent levels, either above the fusion or below the fusion. And below the fusion are the two sacroiliac joints just sitting there. And so it's very common for patients to end up getting diagnostic sacroiliac joint injections, where we're able to diagnose this as sacroiliac joint dysfunction. And then we go on to our algorithm, which ultimately for many of those patients results in the pain tech procedure, which has been extremely helpful. So if you're somebody in the audience today that has a lumbar fusion and you think you have sacroiliac joint dysfunction, I think the pain tech procedure is a great therapeutic option for you. What about other procedures? So have these obviated the need for the pain tech procedure, or do they make it more challenging? And the answer is, even if you've had all these other things like spinal cord stimulation, radiofrequency ablation, injections, you can absolutely be a candidate for the pain tech procedure. So that's one of the things I really enjoy about what I do is we're not burning any bridges. We're still able to do all of the other things we do for all parts of the spine. And if it turns out it's the sacroiliac joint, this procedure is definitely on the table. Can you have an MRI or a CT scan with this? The answer is yes. There's no metal or ferrous or iron-like metal used at all. This is all done with that bone allograft. So absolutely you can have an MRI scan, and you can absolutely have a CT scan or X-ray. Will I get immediate pain relief? And the answer is maybe. So some people do acknowledge having immediate pain relief. Can't really give you a percentage. I would say it's less than 50% in my experience, but for most patients, it takes a few weeks before they really start to have the true benefit of the therapy. But I will say every now and then, somebody in the recovery room is like, I feel great. I already notice it. And I think the big reason for that is that joint distraction part of the procedure. So once you create the space and you hold it open with that allograft spacer, patients can feel that immediate relief. So if that's a big part of their pain, they're going to benefit significantly. Now, the fusion or stabilization occurs over weeks, and that's where the rest of the individuals will start to see the relief is over the course of weeks. And then the last question, the FAQs, what if I have pain on both sides? This is a great question. So I'll tell you that I started doing this procedure about 2 to 3 years ago. And some of the first patients I saw, we ended up doing both sides at the same time. And while you can do it surgically, clinically, et cetera, I will say the recovery was a bit more rough for those individuals because the restriction and not being able to sit. So if both sides are done at the same time, you really can't lean on one side to give yourself some relief. So you really have to force yourself to stand up and walk around or lie down. By doing one side at a time, if you're in a situation where you have to sit, for example, you're driving somewhere that takes longer than an hour, you get stuck in traffic, what people will do is shift to the side that's not operated on so that they can take the pressure off of the operated SI joint. So what I've really moved towards in the last year and a half is doing one side at a time and just making sure an individual or patient recovers fully before going on to the other side. Now, that doesn't mean we have to do it that way. You might have time constraints. You might be one of those people who are like, I just want it one and done. I don't want to go to the surgery center twice. That's fine. It just might make your recovery a little bit more challenging. So we do prefer from a patient feedback standpoint to do one side at a time. I had a patient who was adamant, I want both sides of it. And we ended up doing one side at a time. And she told me afterwards, I am so glad we did, because you don't realize how hard it can be to have a sitting restriction of 1 hour. You know, when you first hear somebody say, they're like, no problem, I can do that. But then you start to realize, oh yeah, I'm sitting in a car. Back when we could go to movies, you sit in a movie for 2 hours. Although hopefully many of you are going back to the movies as things start to open up here with COVID. But there are just situations that you just don't expect. Maybe you're in a social gathering, at a party, whatever it might be, where you find yourself sitting and you start to go, oh boy, Dr. Naidu said I can't sit for longer than an hour. What do I do? So by being able to do one side at a time, you can shift your weight to the side that's been non-operated. So that is my suggestion, but the technical answer is yes, we could potentially do both sides. Next slide.
So we have a few questions that came up today.
Perfect.
In the chat box. First one, my pain is in my low back, but radiates up between my shoulder blades. Is this, can this be a result of sacroiliac joint problems?
Less likely. Usually the sacroiliac joint related pain stays right at the belt level and what we call the lumbosacral band. So sacroiliac joint pain really does not radiate up anywhere beyond the ribs. Sometimes there's a muscle called the quadratus lumborum, which connects the pelvis or the ilium to the 12th rib. And sometimes when people have significant SI joint dysfunction, they will notice that muscle becomes sore and kind of feels some pulling or stretching all the way up to the 12th ribs. But the shoulder blades, those are way up. Those go all the way up to basically from T1 to T7. And so it'd be very, very unlikely, if not impossible, for the sacroiliac joints to cause discomfort way up at that level.
Okay. We have another question that came in. I've had 3 herniated discs happen all at once and very aggressively. I've been treated with no relief. If it is SI related, are the herniated discs coincidental? Is one usually seen with another?
That is a great question. So when we find herniated discs, the question always is that the source of your pain? Because it's what we learned from a paper that came out in 2015 was that 80% of human beings will have a herniated disc by the age of 50, and only a small percentage of those individuals will have any pain related to those discs. So what I'm getting at is that you can absolutely herniate discs and not have any pain at all. It can be an arbitrary, coincidental finding on MRI. So I think the really interesting question for this particular individual is are the SI joints playing a role in your pain? And the only way to answer that question is a diagnostic injection, frankly, where we inject local anesthetic into the sacroiliac joints. And if the individual says, aha, yes, I saw at least a 50% reduction in my pain, then we know the issue is in the sacroiliac joints and not coming from the lumbar discs.
Perfect. That rolls right into kind of this next question. What are the test processes to determine suitability for this procedure?
Great question. So you've heard quite a bit about the history as far as how people present with sacroiliac joint pain. And then when you see me, what I'll do is I'll usually push on the areas of the sacroiliac joint, push on the sides of the sacroiliac joint. It's called compression. We'll do distraction where we pull apart the ilium. And then lastly, we can do a thrust test where we push the femur back and open up the sacroiliac joint posteriorly. So there's some provocative maneuvers there. Then we can look at imaging, which is a plus minus, because sometimes, Patrick, you'll see some inflammation on MRI or on the x-rays, and sometimes you won't. But that doesn't necessarily rule out the sacroiliac joint as the source of pain. So what I'll tell people is that imaging doesn't play a huge role in the workup for the sacroiliac joints, but sometimes you can see it there and go, oh yeah, maybe that contributes to the idea that the sacroiliac joint is the source of pain. And then the true diagnostic test is the local anesthetic injection. And sometimes we'll just put in steroid as well, because look, if you're going to get a few hours of relief, why not take it out to a few weeks or months of relief with a steroid? But if you're looking solely for the diagnostic aspect, the local anesthetic, the longest lasting local anesthetic is bupivacaine, also known as Marcaine. It lasts about 6 to 8 hours. And that's about the window of time in which you will feel relief if the sacroiliac joint is the source of your pain. Now, on the flip side, if you get that injection done and you go, that didn't do anything for me, I still have back pain, don't be frustrated. Don't be upset. That's a good thing, because it tells us, okay, your sacroiliac joints are not the source of your pain. It's something else. Like in this patient who had the 3 herniated discs, maybe he or she gets the sacroiliac joint diagnostic injections and does not have any relief. Well, now we're back to the drawing board. Now we're looking at whether it's the discs, whether it's the facet joints, whether it's stenosis, because there is a degeneration cascade of events that occurs when it comes to the lumbar spine. So it's not easy, as you can tell, to figure out what is the source of pain.
Great. Is there physical therapy needed afterward?
After the procedure, I'm presuming?
Yes, I'm presuming.
Yes. So after any procedure, for those of you on this call might know, I do spinal cord stimulation. I do another procedure called Vertiflex and Relievant, and as in the pain tech procedures, another one of these cutting edge newer technologies that I'm doing. For every procedure, I marry it with physical therapy, and the reason for that is your body is going through an adjustment. As I mentioned, we distract the joint and we put in the spacer, and there's slowly going to be this fusion process over the next several weeks. And as you do that, your body goes through an adjustment. So the lumbar spine will feel a little different. The hip will feel a little bit different. So I really put a lot of emphasis in doing physical therapy after these procedures, because it helps reorient and recondition those areas of the spine, hip, sacroiliac joint, and pelvis, so that you can see a much better outcome or result. If anything, it prevents other issues from occurring, which can happen after certain procedures. So I always recommend doing physical therapy after this, once you've gone through the acute healing process of the procedure.
Another question came in. Can I still get adjusted by a chiropractor? I would imagine at the conclusion of this procedure.
Yeah, so after you've gone through the acute healing, once everything is stabilized, so that takes about 6 weeks, then we can open it up to other types of therapy. It's important to tell the chiropractor your SI joint had this procedure, so that they should not manipulate the SI joint with great force or vigor. But other parts of the spine, sure, they can work on. You just want to make sure you don't cause any major issues around the sacroiliac joint.
Thank you. Another one came through. How big is the articulating surface of a normal SI joint? One diagram seemed to show it's a centimeter or 2. Another indicated the length of the medial iliac.
So this is maybe, Patrick, if we can go back to some of the images of the sacroiliac joint. So this is a very strange looking joint. So if you think about a knee, joint. I think all of us can sort of imagine what that is. You have two bones, that are sort of flattened but yet rounded, and you put them next to each other, and okay, that's a joint. That makes sense. Or you think about the hip joint as a ball and socket. Yeah, that makes sense. The sacroiliac joint is a really funny looking joint. Okay, so the sacrum, if you look at it from the side, is a triangular taper. So it basically thins out as it goes backwards. And the ilium, as you can see, is this big, almost like the palm of my hand, is this wing that hangs out off to the side. So the actual joint space, when you go from front to back, can be as long as 4 inches, depending on how big the individual is, and as short as even 2 inches or just under that. And then going from top to bottom, it can also be about 4 inches long, which is pretty significant, or reduced down, depending on the size of the person, down to 2.5 to 3 inches. So again, what we're thinking about are in different dimensions. And then with those 2 dimensions, this joint is not box-like. It is triangular in one dimension, and it is tapered in another direction. So it looks very bizarre. The inferior aspect of the joint, below where you're seeing this blue space or the circle, is actually where most of the volume of the joint is. So if I filled that joint up with fluid, most of the fluid would be in the bottom aspect of the joint. But what's interesting is that doesn't mean that's where all of your problems occur. Your problems could be anywhere around the top, the bottom, the middle, further towards the front, further towards the back of that joint. And that's why some therapies fail and other ones persevere. So why I think the pain tech procedure is more advantageous is you're creating that distraction, that space, and then you're holding that space open with this allograft. And so if your issue is more towards the front or the back, it doesn't matter because you created more space in that entire joint. Whereas if you look at another therapy like radiofrequency ablation, where we burn the nerves that are coming out from those holes, if you look at the sacrum, if Patrick, you can point out where those holes are in the sacrum, and then going towards the joint, what we do is we burn those nerves. That will only address the pain on the back of the joint. That will not address the pain on the front of the joint. So that's why I think this therapy is actually advantageous or better than the radiofrequency ablation procedure, because you're getting both sides of the joint addressed.
Great. That rolls into our next question. It's more of a 2-part question. Do you sometimes only need to do one of the joints and not the other joint? Have an RFA scheduled. Any reason to do the link procedure first?
Yeah, there may be reasons why we chose to do the radiofrequency first, or whoever your provider is to do the radiofrequency first. It's a fine procedure. It's a needle-based procedure, and if it works, great. I think the only issue is, sometimes the pain can return within a few weeks or a few months, and then the question is, what are the next steps? And there's been evidence for that procedure too, so I do not want to discount it, and it's a procedure that I do as well. But I think if we're looking for a therapy that can provide more sustained relief, going out months and years, this is the therapy that I think is next in line. So I don't want to discourage you from your treatment plan as is with the radiofrequency. I think you should consider that. There's no harm in doing it before the pain tech or link procedure. But if it doesn't work out as well as you'd like, or it doesn't last as long as you'd like, this should be an option for you.
Great, thank you. My only pain is when sitting down or laying down. Can walk and stand without pain.
Yeah, so this might be a pain generator. The other possibility, based on what I just heard there, is sitting and lying down. It could be a disc. So again, that's where sort of the complex puzzle of pain management and orthopedic practice comes in. So if it was really easy to diagnose these things, we'd make robots do it. But that's why I have job stability, because it's complicated. Pain with sitting and lying down usually means a disc or a sacroiliac joint. But the way we'd figure it out is by looking at the imaging, doing a physical examination, and then potentially doing a diagnostic block, either of the sacroiliac joint or an epidural for the lumbar spine, and then figuring it out from there. So if you're somebody who already sees me, let's talk about it when we see each other again. Or if you don't, maybe come in and see me and we can try to figure that out.
Great. A few more questions, then we'll be all set. When can I play golf again after the procedure? After an hour of sitting, how long before I can sit again?
Absolutely. So that should be in our FAQs, because I get that asked more than any other question. So for the golfers out there, because your swing really does put a lot of strain on the SI joint, and I've done this procedure probably more on golfers than any other hobby or sport or athlete, because golf can really put its toll on the sacroiliac joints. So I really do recommend waiting 6 weeks before getting back into the full swing of things, no pun intended. Does that mean you can't putt, 3 or 4 weeks or do some, training and stuff? Sure, you can. I just don't want you to do a full swing for 6 weeks. I know you love the game. I know how hard that is to do. But if you really want to see the full benefit, I'd recommend staying off of golf for 6 weeks, at least the full 18.
All right. Next question. It's another 2-questioner.
Sure.
First, I've had many sessions of prolotherapy, initially with lidocaine and dextrose, and then with lidocaine and phenol. Am I still a candidate? Second question, my internist thought that my pain is from the QL. Can you determine if it's truly QL or if it's SI?
Yeah, great question. So if you've had prolotherapy, yes, you can absolutely have this procedure. Prolotherapy does not interfere with it. As far as the QL, that's a possibility. That would use, and I think I talked about this already, that connects the 12th rib to the ilium. As you can see on this diagram, they call it the hip bone, even though it's not really the hip bone, but it connects down to that ilium. So the QL dysfunction would cause some discomfort in the lower 12th rib all the way down. So that's usually done by history more than anything else. And sometimes physical therapists, or we'll put pressure on the QL, and then once we release it, you can notice some relief or increase in pain. That again goes with the QL. But that should be very distinct from the sacroiliac joint, where you can really create some pain with provocative maneuvers, as I mentioned, compression, distraction, something called the Fortin's finger test, or the Patrick's test, where we take your leg, we put your ankle up on your opposite knee, and then we put pressure down on the knee to create tension on the sacroiliac joint posteriorly. And if that causes you discomfort, that's a positive test. So to distinguish between the two, it can easily be done in the office.
Okay, great. Is there an age limit with this procedure? And does Pain Tech help with stenosis?
So there is no age limit. We tend to see this issue as people get older, but again, there are younger people who have this issue as well. So I do not want to exclude people in their 30s, 40s, or 50s. Absolutely, there are those individuals. As far as stenosis, no, this procedure does not address stenosis. Stenosis, what that is narrowing of different compartments or windows of the spine. They talk about stenosis for arteries and veins as well, but of course we're talking about orthopedic or spine-related issues. This procedure is not meant for stenosis. This is meant for the sacroiliac joints being a source of pain.
If I had a vertiflex and still have pain in the SI joint, can I have this procedure?
Absolutely. And I might have seen whoever asked this question recently, but we have seen some people who get relief from vertiflex with one component of their pain, but their overall picture doesn't change because they have SI joint issues. And absolutely, you're a candidate for this procedure after the vertiflex. I can think of at least 5 people who've gone on to have this procedure after vertiflex, and they're doing really well. And those were some of the same people who basically said, you know what, I'm not sure the vertiflex really helped me, even though they had very clear stenosis on their MRI and had symptoms of neurogenic claudication. They also had SI joint dysfunction. And so one of the challenges for me, it's like peeling an onion. We can address one issue, great, but you still continue to have overall low back pain. Then we have to get to the next issue. And sometimes we get to a third issue, and sometimes we get to a fourth issue before finally someone says, all right, now we finally got it. So that is the complexity in pain management, is that there often isn't just one thing. We sometimes have to do multiple things in order to see someone truly improve in their overall quality of life.
Great, thank you. Final question we got today.
Okay.
I've had injections in my facet joint in the L5 and S1, and I've had a fusion in L4 and L5. Is radiofrequency ablation the next logical step?
Well, it depends. So radiofrequency ablation is dependent on diagnostic blocks. So what we will do are, for example, for the facets, are medial branch diagnostic blocks, say at L5, S1. And if those provide at least 70 or 80% relief, that tells us, aha, those joints are playing a role, or those nerves are playing a role in your pain. Now we can go ahead and radiofrequency ablate those nerves. It's the same thing we do for the sacroiliac joint. Same thing we do for the knees, the shoulders. We do diagnostic tests first to make sure that those nerves, if ablated, will be helpful to you. Now, hearing this history of L4-5 fusion, and now potentially have radiofrequency ablation, and here we're talking about pain tech, there's a lot of work we need to do. So I think we would need to figure out first, what are the pain generators? Is it the facet joints, number one? Number two, are the sacroiliac joints playing a role? And we would do that by doing a diagnostic sacroiliac joint injection. If that is the case, and we happen to do a second one just to confirm it, and it shows that yes, you've had at least 50% reduction in pain from the sacroiliac joints, then we're moving towards the pain tech procedure for the sacroiliac joints. But as you're hearing, you can have multiple sources of pain. So when you are fused at L4-5, yes, your L5-S1 facet joints can be a source of pain, but your sacroiliac joints can be an additional source of pain. So for us, it's either figuring out, is it the one or the other or both? Or is it even something else, like stenosis above the fusion? So that's a classic picture, what this patient just described. I think we still have a lot of work to do to figure out what are the sources of pain and what are we going to do about them.
Great. Well, that pretty much wraps it up. Again, Dr. Naidu, if you have any closing remarks, feel free to let everyone know. Again, I will be following up with everyone that's on the webinar, and it is being recorded. So when I follow up with you and you want to receive the recording, just let me know and I can send it over to you.
Perfect.
And thank you all for joining us. And go ahead, Dr. Naidu, if you have anything
else.
Yeah,
I again want to thank everybody for attending and also asking great questions. I want to reiterate, we are talking about one specific condition here, the SI joints, and many of you have asked questions about all sorts of other pain generators, which is awesome, because for many of you, we're struggling to figure out, is it the facet joints? Is it stenosis? Is it the nerve root? Is it the foramen? Is it a disc herniation or a bulge? Is it the basivertebral nerve? Is it a compression fracture? And what you heard today here was that for one specific pain generator, the SI joints, we have a really good therapy available for you. So hopefully you've learned a little bit today about my job and how I do things and what my logic is like. And if this therapy and this diagnosis kind of sound like something you're interested in, please come and see me. Happy to talk about things and figure out how we go forward with the next best steps. So again, thank you everyone for joining us, and looking forward to seeing you soon. Take care.